We have a nice group of people here, and the title of the session is System Approach to Healthcare Design. We have quite an interesting group of papers, 5 papers that are dealing with systemic view on healthcare, and there are also some interesting case studies. So I think we will have a nice discussion. Since this is the first conference session for this year, I would say a few basic information. Fanica is our helper, and she will help us to manage to this session. You can also ask her about any question about technical questions about Huynh if you have a problem. So far, I don't see anything like this. And she will run the presentations. We will work in a manner that I will introduce every speaker very shortly, and then we will have a presentation. Please use chat window to enter your questions. And after the last presentation, which will take about 30-35 minutes, we will have, I hope, a fruitful conversation and discussion about the questions that are raised during the session. Now, let's go to the first speaker. This is Alix Feldman. And the title of the presentation is Driving Change in Complex Social Systems, How to Design Healthcare Pathways. This is an interesting case, and I'm very personally interested in that case. The good point is that I have these hearing aids, so I could not have 2 of them simultaneously, but I'm one of the users. So I have a real nice interest in that. The paper is written by Alix Feldman. She will present it. François, Patou, and Anja Maier. And Alix is a PhD student at DTU. And she is interested in engineering systems, responsible innovation and design. Her research investigates the association between hearing loss and cognitive decline and explores the integration of complex healthcare interventions into clinical practice. Alix, I believe the mic is, we will see your presentation now.
Welcome to my presentation titled Driving Change in Complex Social Systems, How to Design Healthcare Pathways. It's written by myself, Alix Feldman, as well as François Patou and Anja Maier. In the healthcare system, fast-paced developments are often at odds with more conservative and stringent regulatory requirements. These are used to keep us safe, as healthcare is a system with an extremely high risk and life on the line, and therefore a very small room for error. Protocols are a set of steps, a plan, used to assess a patient and determine appropriate interventions. They're designed to increase uniformity and maintain efficient patient care. However, plan and practice aren't the same thing. Patterns of action are always changing in practice, and it's part of what makes healthcare clinics complex. Even when protocols and guidelines are followed, the way in which they're done is highly dependent on the people in the clinic, their knowledge, their experience, and the way they interact with one another. While everyone has the same shared goal of achieving more effective health outcomes, the routes that are taken and the trade-offs made along the way can add to the system's complexity. This paper uses observational research compiled over 12 months in the clinical setting. During this time, we ran a case control study described in the article listed here in BMJ Open. We participated in team meetings and consulted regularly with doctors, nurses, and other members of a memory clinic in Denmark. We consulted with over 50 patients with cognitive dysfunction about their hearing history. Together with current ministry guidelines, these experiences and encounters resulted in a mapping of system actors within the cognitive care system and the diagnostic care pathway for an individual experiencing cognitive dysfunction. We know that hearing loss is one of the largest and a potentially modifiable risk factor for dementia in mid to late stages of life. But we want to know how we can integrate new knowledge about this risk factor into routine clinical practice. This is an overview of the actors within the memory clinic. It includes those personally affected by cognitive impairment, such as patients, primary caregivers, and spouses, as well as practitioners, both in and out of the clinic, and non-human actors, such as electronic patient journals, appointment booking systems, and laboratory tests. When new actors were introduced, we became a temporary part of the care system. We directed attention to new ways that care could be addressed, we identified new care needs, and we were able to co-design with need knowers and patients. In this way, we became the spokespeople for these components: the audiometer, the hearing aids, the results of hearing tests. All of these new tools shifted and sometimes challenged the current routines in the system. This is how we map the dementia diagnostic pathway in our project. We started with a person or a caregiver noticing subjective difficulties in areas such as memory and attention. After a referral to the clinic, they go through a series of diagnostic steps, the protocol, before their diagnosis is confirmed by a team of practitioners and the care journey begins. Our research became a temporary part of this cognitive care system, which was introduced during checkups and control visits. This provided situational evidence, as only 26% of the patients we tested had normal hearing and could participate further in the case control study. This meant that 74% of patients had hearing loss, and one that would have otherwise gone unchecked in this particular system. This illuminated a potential entry point for a new care delivery pathway. These eligibility screenings became counseling sessions as we shared results of the hearing test with patients and their spouses, and potential next steps were discussed. Clinical staff also became familiar with the presence of the hearing equipment in the clinic. In some cases, the referral for these patients with their practitioner in the clinic began a conversation about a risk factor that would have otherwise not been discussed in this visit. Hearing loss was extremely common among patients in the memory clinic. These findings aren't entirely unexpected, as previous research alludes to the high prevalence of hearing loss in this age group. However, the information about the hearing loss in these patients was new within the clinic. We know that patients often underreport their own level of hearing loss, or they don't interpret their difficulties as an explicit loss of hearing. However, with time, it can exacerbate or trigger the experience of cognitive difficulties. For those that we tested who were aware of their hearing loss and had at one time been given hearing aids, a majority were no longer wearing them, or their hearing aids were no longer fully functional and were in need of repair or replacement. This is a huge opportunity for synergy in care practice, as the care and management of hearing aids is particularly difficult and ever more important in this patient group. In this paper, a systems-based design lens provided us with the opportunity to work concurrently with design and clinical research to reframe clinical endpoints, illuminate new entry points, and to identify barriers to and enablers for change. In future, audiological screening could be integrated into the earlier stages of the diagnostic process to identify those who are at risk. Research should continue to identify viable synergies within the wider cognitive and the hearing care systems. A special thanks to the patients, caregivers, and practitioners, as well to our collaborative partners for their invaluable work and support during this research project.
Thank you, Fanika, for this nice presentation. Let's go now to the... Is there any ad hoc question before we go into the second presentation? Okay, let's go to the second presentation, which is quite interesting. It is title is a little bit intriguing. Anybody listening? A citation analysis of healthcare design research articles published in design journals. This is an interesting article because it goes to the number of journals and discusses the citation that is a key metric in academia. The paper and the work will be presented in presentation by Guillaume Lamé, and I hope this will be an interesting also session, and it will raise some questions after that. Please, Fanika, can you start the question? The presentation, sorry.
Hello, so I'm Guillaume Lamé and I'm presenting the paper. Is anybody listening? A citation analysis of healthcare design research articles published in design journals. Work that has been done with Solène, Huynh-Dagher, Alexander Komashie, Marija Jankovic, and Duong. So our objective was to better understand the impact of healthcare design research in health sciences. So we wanted to see how a subset of design research that focuses on healthcare had or had not been influential in health sciences, had or had not been picked up by researchers in medical research, public health, nursing, health policy, health services research, etc. So to do that, we've conducted a systematic review of 6 design journals: the Journal of Engineering Design, Research in Engineering Design, Design Science Journal, International Journal of Design, Design Studies, and Design Issues. Now, the content of the systematic review is not the point of this presentation. The content of the systematic review is under review for a journal, and it's out of scope today. But suffice it to say that we've included 44 articles from those journals, and that we have then analyzed the citations of those articles. So we have identified 472 citations, excluding self-citations, meaning that if one of those 44 articles cited another of the 44 articles, it didn't count. So 472 citations excluding self-citations. That's our focus today. How have we analyzed those citations? Well, we've simply used the Web of Science's categorization of journals, which is in 3 levels. First, a level called categories. There are 5 broad categories: arts and humanities, life sciences and biomedicine, physical sciences, social sciences, and technology. Each category includes a number of research areas. In total, there are 154, and those research areas include 1 or more Web of Science categories. There are 254 Web of Science categories in total. And it's important to note that one journal can be in multiple sections. So the International Journal of Design is in the technology, arts and humanities, and social sciences categories. And for instance, for technology, it is listed in the engineering research area and in the manufacturing and multidisciplinary Web of Science categories. Which means that some citations might be counted twice for each of the categories that the journal belongs to. And we haven't been able yet to correct for this, nor would we be able to, I think, because this would mean choosing one specific category for each journal. Now, looking at the level of categories, so technology is the biggest category that cites our 44 articles, and the second one is life sciences and biomedicine, which includes all the healthcare-related journal, but also includes areas like fisheries, like animal biology, etc., which we're not that interested in. So we can, so this would be nice to think that life sciences and biomedicine is not far behind technology, but we need a finer analysis. So this is why we turn to research areas. So these are all research areas with more than 10 citations for articles in our sample. You can see that engineering is really predominant here with 195 citations. That healthcare related fields are much further down the road. So healthcare sciences and services, the first one, has only 36 citations, so 6 times less. Then you have public health, rehabilitation, and medical informatics listed here, and there are a few other healthcare-related fields that have less than 10 citations. If we look at the lowest level of categorization, Web of Science categories, so those are all the Web of Science categories with more than 15 citations for the articles in our sample. Engineering is splitted here into industrial, multidisciplinary, and manufacturing engineering. And we can see that it's still pretty dominant. And there is no major change in the balance between healthcare-related fields and others. You can see that engineering mechanical appears here, engineering electrical, electronic, etc. So there are multiple kinds of engineering appearing in the ranking, but healthcare-related categories are still lower. So, in terms of research areas, we have 195 citations in engineering, and the first healthcare research area is healthcare sciences and services with only 36 citations. In terms of Web of Science categories, only 21.2% of the 836 citations analyzed were in the health-related Web of Science categories. Whether we are happy or not with this is a matter of judgment, but it does seem low. We included only articles that dealt with healthcare issues, and many of them were case studies. They were not methodological design articles. They were case studies of application of design approaches to real healthcare issues. So it does seem low that only 20% of the citations of those articles come from health-related journals. Of course, the results depend on our initial choice of journal, our search query, etc., and are clearly biased by the multiple indexation of some journals, and we would have to investigate if healthcare-related journals are as likely as some design journals to be indexed in multiple categories. But we've looked at recent reviews on design thinking in healthcare, for instance, and they haven't picked up any of the articles we have included. So there is a feeling that healthcare papers don't pick up on our research, which we think is problematic. The interpretation, we can only make hypotheses. Is it that our research is not visible? Is it that we're not producing research that healthcare researchers like because it's not evaluation driven? Or is it that we simply publish two papers, one for design researchers and one for healthcare researchers when we do a project? This is the kind of things we have to investigate further. So thank you very much for your attention.
Okay, this was a presentation about citation in healthcare journals, and also I would like to introduce now the third presentation, Atypical use scenarios as design intervention in healthcare product design application. The presentation will be presented by Kamya Nagarajan from Singapore University of Technology and Design in Singapore. Kamya is also a PhD student working on the usability of medical device designs. Prior to her PhD, she has experienced working in human factors projects for automotive design. I think this is also one interesting presentation, and Fanika, please let us see it.
I welcome you all to my presentation today. I'm Kamya, a PhD student from Singapore University of Technology and Design. Today, on behalf of my all co-authors, I am going to present on the topic of atypical use scenarios as design intervention in healthcare product design application. Here is a background to emphasize the importance of considering use error and usability in medical device design. Medical errors are the third leading cause of death in US. 36% of the device recalls is because of the design. Adverse events associated with medical device are more often the result of use error. Some of the examples of device recalls due to poor usability are a glucose meter was recalled because its users interrupted the number on the display as 22 instead of 2.2. As a result, the users thought their blood glucose levels were 10 times higher and would mistakenly believe they needed to adjust their insulin injections to a much higher level than necessary. Similarly, an ultrasound device was recalled in which the users made an assumption that the patient's right and left sides were oriented in the same direction as a transducer. Atypical scenarios are the ones deviate from the standard expectations of unwanted events or worst-case scenarios which are not identified by common hazard identification techniques. Literature shows the benefit of including users' in perspective in medical device development, and adverse event reports help improving the design of new and existing medical device design. In this study, we use atypical scenarios and adverse event developed from the input of clinician as design intervention into students' healthcare product design projects, which follow a water flow model of product development process to understand if the intervention has helped improving the usability in their designs they're working on. This study poses a couple of research questions, which are: how did the design intervention benefit the students in understanding device use and usability of their product design? How did the design intervention impact the usability aspect in the conceptual design outcome of the project teams? This is the methodology we followed in the experiment process. There were 8 project teams working on clinical problem each. To brief them overall, the projects were on expiratory trainer for patients with Parkinson's disease, portable device for leg elevation for the patients with leg injuries, a device to monitor inhaler dose to ensure patient compliance with prescription, a device to guide one or more needles for tumor ablation, a pediatric wheelchair for growing kids with neuromuscular conditions, a device to train coordinating limb movements in infants with neuromuscular conditions, a portable endoscope to operate basic ENT procedures by general practitioners, a device to provide superficial heating for patients with affected upper limb. Each team was given 2 different atypical scenarios. For example, this is the atypical scenario given to Project Team 5 working on pediatric wheelchair for kids and neuromuscular condition. These scenarios were framed based on the input given by the clinicians during their interview about the extreme use conditions, adverse events, and the types of users highlighted by them. We added personas to make it more realistic scenario relevant to the project. Analyzing the user need statements before and after the design intervention, all the teams modified at least one user need to meet the atypical scenario. For example, Project 1 came up with a more specific user need and added a new user need to add hand grip to increase the holding stability. Project 8 modified the user need more specific on the stop button position and added a new need based on the atypical situation given to them. Post-design survey conducted among the students showed that 92.5% agree that they were better able to empathize with their target users. 97.5% agreed that it invoked the ability to visualize atypical environment. 90% were able to imagine situations that might happen to the users while device use, and 70% asked more questions to their clinical mentor about various use cases and use environment. This was helpful because considering the COVID-19 situation, project teams could not visit the clinics, hospitals to see the patient's behavior and the environment. Design evaluation was done with 3 different evaluators, and they evaluated 16 design evaluation sheets. The usability criteria was based on the ISO standard, and they rated on the scale of 1 to 5, where 5 being the highest. We calculated the inter-rater reliability. The Cronbach alpha value was 0.621, and the intra-class correlation with 95% confidence interval lied between 0.3 and 0.7. Rater A and B scored the projects 1, 2, 3, 7, and 8 better under one or more usability criteria, and Rater C scored 1, 2, 4, 6, 8 better as under one or more usability criteria. The findings answered our research questions we initially had. The post-design activity survey showed that the design intervention considering atypical scenario has benefited students in understanding the device use, the emphasis on the usability and ability to empathize with end users. The impact on the design evaluation, the user need analysis showed that the intervention improved usability of 5 projects out of 8, and 1 project showed no change, and 2 projects had partial effect. These could lead us to discuss on the limitations of the study. We noted some limitations in the study, which is also an opportunity to improve the experiment in the future, such as the insights were collected only from the clinical mentors, even though there were some projects which the end users were patients. Information for atypical scenarios were gathered from clinicians from week 2 onwards, depending on their availability. In week 6, many students felt that the design activity could have been conducted earlier to implement the improvements. The design evaluation sheet consisted of drawing models which were submitted by the students, and each individual team progressed every week in a different way. Evaluating usability, especially task efficiency, was challenging without a physical prototype for the evaluators. We see this study as an attempt to emphasize the importance of usability in healthcare product design projects among student designers. Though the likelihood of atypical scenarios to occur is less, considering the consequences, it is helpful to incorporate a need-finding process. Thank you for your attention.
Professor, please just unmute yourself.
Thank you, Veronica. You would hear me a little bit better if I unmute my mic. That's for true. I don't see any questions in the chat window, so it seems to me that you are quite inactive, or something is wrong with my system. We will leave this to guess what is the case. However, we are now going to the third presentation, the role of systems approach in health and care. The presentation will be presented by Alexander Komashie from University of Cambridge. Alexander works for a long time in healthcare design, and he is a senior research associate in the Department of Engineering, Healthcare Design, and postdoctoral interdisciplinary fellow at the Healthcare Improvement Studies Institute at University of Cambridge. Alexander is working for a long time trying to understand the complexities of healthcare system, and this is one of the work that I believe is on just another project that Alexander will work on for a few next years. So let us see this presentation, and I hope there will be a lot of questions on it.
Good afternoon. My name is Alexander Komashie, and on behalf of my co-author, Professor John Clarkson, I want to present our paper on the role of systems approaches in health and care. When I say health systems, I wonder what comes to your mind. Is it something like this, the national system, or is it something else? Well, that is what we hope to explore in the next few minutes in this presentation. First of all, you would agree with me that the essence of health is people. It's all about people ultimately. And it's also a fact that there is no health without systems. It involves various elements, information, technology, staff, patients, families, and other elements interacting together. These systems need to work, and this quote from the Royal Academy of Engineering in the UK is very helpful. It says that systems that work do not just happen. They have to be planned, designed, and built. This raises the question, how do we design a health system if it is the national thing? There is a more basic question before that. What is health in the first place? In the current literature, health has three key elements or components: mental, physical, and social. But that hasn't always been the case. Before the establishment of the World Health Organization, there was a traditional medical model of health that was mainly about physical health and focused primarily on the absence of disease. When the WHO was established in 1964, there was a shift towards a more universal idea of health, and hence the definition on your screen Health is a state of complete physical, mental, and social well-being, and not just the absence of disease or infirmity. And the pink bars or pillars on your screen indicate the completeness is full in each of those three aspects. This has its problems, as various people have debated the appropriateness of the universal definition. One of the critiques is about the social element of the definition. It has been argued that by making social well-being part of health, we may be medicalizing people's social problems, and that may not be appropriate. Others have argued that even if we include social well-being, is it necessary that everyone should have complete state of physical, mental, and social well-being to be healthy? It's been argued that if that is the case, most of us will be unhealthy most of the time. And within the literature, the idea of health system is often used to represent the health care delivery system. And you can see that distinction in this definition from the World Health Organization. That the green text on your screen refers to aspects of care or health care, whilst the red text refers to elements of health which do not include care. For example, encouraging the Ministry of Education to promote female education does not include care, but it's very much about health. And it's all about personal health. Now, when you take a population approach to personal health, you are in the field of public health, which is also very much about health and often is not part of the health care system. Our interest is to propose the definition of a health and care system that aids design. And what we propose is a health and care system is a collection of people and entities that work together to achieve a defined health and care objective. So this is a health and care system. That is a health and care system. It's a health and care system. So this brings us back to our previous question: how do we design health and care systems instead of how do we design health systems? And we have three approaches which come from the work within our health system design SIG within the Design Society. The first one is a techno-behavioral approach, which comes from the previous Engineering System Division in DTU, Denmark Technical University, highlighting healthcare delivery or health and care delivery, technology, and behavior. The idea emphasizes the importance of human behavior as key to any intervention to improve health. The next one is about convergent health design approach, which is from TU Delft in the Netherlands, emphasizing the idea or the need to remove conceptual, methodological, and knowledge barriers between design and health and care. It argues that maximum impact comes from maximum engagement. So the main driver is to facilitate engagement between design and health, and also between health providers and health recipients. And finally, we have the engineering better care approach, which was developed in the University of Cambridge, emphasizing 4 key perspectives that should drive improvement in any health and care system. So in brief, we conclude with these thoughts of health systems being often used to refer to the national level, and propose a definition of health and care systems, and also presented 3 approaches to health and care system design. And we hope that this will stimulate further discussions around the language of health and care in design. Thank you.
Thank you for the presentation we have just seen, and we are now going to our last presentation. This is the presentation from Malta. It will be presented by Edward Abela, and the title is a novel user-centered framework for the holistic design of therapeutic medical devices. Edward Abela is a researcher at the University of Malta, and he is a mechanical engineer and worked in the manufacturing industry, and now is reading for a PhD in engineering, specializing in medical devices. I'm looking forward to see the details of this presentation, and later on I hope we will have a discussion on all the papers. Also, since we are less than 20 in a session, I think that you can ask our moderator, Farika, to let you in with video and audio. Please mute your mics, and maybe the discussion will be easier if we can see each other. The system enables up to 20 simultaneously visible participants, but everybody can listen and chat. There is no limit for that number. So Farika, please run this presentation from Edward. Thank you.
Good afternoon, I'm Edward Abela, a researcher from the University of Malta, and today I will be presenting our paper titled A Novel User-Centered Framework for the Holistic Design of Therapeutic Medical Devices. In the presentation, I will start by giving a brief introduction about the study, followed by a description of the methodology and the proposed set of requirements identified. A case study will also be presented together with the overview of the outcomes and conclusions from our research. So in literature, user-centered design generally supports the design of safe and effective devices, which are also satisfying and engaging during use. However, there is a need to support designers to enable them to take the necessary user experience and regulatory considerations during design. And the scope of this research was therefore to identify different set of requirements with respect to patients, clinicians, and designers, which were essential for the formulation of a framework supporting the designer during medical device design. Such research area has been addressed in recent years. In a recent study by Lieberman and Biden, the author proposed a user-centered methodology targeting functionality, usability, and aesthetics. However, this study did not consider and address the regulatory implications during design. In a separate study by Shah et al., a theoretical framework was proposed for directly involving patients and healthcare professionals during the design phases. However, regulatory implications were not considered. And in another study by Dunn et al., the study addressed medical device innovation through prioritizing user experience requirements. However, it did not integrate regulations within the proposed solution. And additionally, in a study by Santos, a methodology was developed considering regulatory and commercial implications. However, it is not a user-centered methodology, and no user experience considerations were made. So therefore, the above literature demonstrates the need for a framework considering regulatory compliance and user experience through a user-centered design approach. As described by the methodology presented over here, 3 different studies were conducted to identify requirements from 3 separate user groups. In the first study, presented in a previous publication by Abela et al., 16 participants were recruited to identify a set of requirements for clinicians managing rehabilitation products. In another study, 24 patients were recruited to determine preferences regarding different product properties. And lastly, a study with 15 participants was undertaken to identify the areas where designers require guidance during rehabilitation product design. A total of 16 requirements were generated as follows. The first set of requirements were presented in a publication by Abela et al., and patient requirements include maximizing product functionality, designing engaging products which offer high quality user experience and a high degree of customizability. And also designer requirements include communication with end users, guidance on regulatory implications, identification of critical requirements, and enhancing innovation and creativity through design. So based on the identified requirements just described, a preliminary framework with the name of MetPro was proposed with the aim of providing design support during the developable device design process. The framework is made up of 5 different stages, these being task clarification, conceptual design, embodiment design, detailed design, and product release. And given the user-centered approach adopted, the 3 user groups were kept at the center of the framework. The framework is composed of 4 concentric layers. The first layer provides guidance on product design based on the acquired personas and bespoke patient characteristics. The second layer provides guidance towards medical device testing, including early performance testing and verification testing. The third layer concerns regulatory approval and assists the designer with devising the most adequate regulatory strategy, while the final layer provides guidance related to the product development process to increase its efficiency and effectiveness. The next step was to apply the MetPro framework within a case study for designing a set of bespoke rehabilitation devices targeting the motor function of the upper limb. And initially, the MetPro framework supported the designer to identify a set of requirements pertaining to the patients in consideration. A set of personas were then generated in order to classify the different physiological and anatomical characteristics of the patient. The designer was then guided to generate ideas and develop concepts whilst conducting initial spatial analysis and exploratory testing. A verification validation test plan was formulated, which allows the testing strategy to be realized in line with the requirements identified. And then a regulatory strategy was developed to suggest the designer the applicable standards and regulations which are relevant for the design of the controller in hand. The MetPro framework also suggested the different optimization techniques in order to apply these and enhance the design of the products, whilst a set of prototypes were developed which are currently undergoing different rounds of testing as proposed by the MetPro framework itself. So some conclusions made from the study are the following. The main scope of the study was to identify requirements for therapeutic medical devices from different user groups pertaining to patients, clinicians, and designers. A framework was developed assisting in the design of safe and effective products in line with the applicable regulations and user experience considerations, placing the user as a central contributor towards medical device design. The main contribution lies primarily in the integration of 3 sets of requirements into a novel framework architecture for the holistic design of medical devices, and the case study was considered demonstrating the various ways in which the framework can provide insights and transform the design of medical devices. Future work will endeavor in validating the framework with designers working in the medical device industry. I thank you for your attention. I hope you found our research and studies interesting, and I hope you also found the presentation engaging, and I look forward to answering any questions that you might have.
Thank you very much, Fanica, for running these presentations to all of us. Now, I believe there will be some interactivity in discussion. I have seen that some discussion has sparked already in a chat window. The questions have been more or less answered or commented. There's not questions, but more comments. And here we have a question from Anja, Maier to Julian. Julian, please take time to read these questions and try to answer. Also, again, a reminder to everyone, ask for joining, sharing the video, and Fanica will let you in so we can discuss interactively.
Yesterday. Okay, so I've seen that
two questions. Hope you can hear me. There was one by John, which I haven't answered yet, and one by Anja about my paper. So John is asking, should we shout louder or shout differently? In the beginning, I thought that, John, you were just having difficulties with your microphone, and then I understood that this was about the paper. And then Anja is asking, how might the numbers look like for design researchers publishing in medical journals? Okay, the quick answer to this one is I don't really know, because it's difficult to pick up research that is published by, I mean, how do you distinguish a design researcher from someone else just in the list of authors? We could try to look for what we people have been publishing in medical journals and see what happens. How might your analysis compare with design researchers publishing in design journals referencing coding? We do include citations by design journals in our analysis. We don't include citations. So if one article in the sample cites another article in the sample, we haven't included that. But if, say, another paper in a design journal, in the Journal of Engineering Design, cites one of the paper in our sample, it works. But the kind of hierarchy is very similar if we include self-citations, so it doesn't change much. And I think the last question is a bit similar to John. So who would we like our work to be picked up by? And yeah. I guess one of the comments we had in the reviews or this review, or the reviews of the systematic review itself, was that people will sometimes, if not often, try to publish the work they aim at design researchers in design journals, and anything that they want for a broader audience, they will try to put in a medical journal. And if they have medical co-authors, the important part for their careers will be the medical journals. So possibly there are I think double publication strategies are important here, and that's something we need to look at and think about. And I think that's something that has been very visible for social scientists, for example, in the past. And if you did the exact same analysis with medical sociology papers, they would be probably equally disappointed. There's a lot of sociologists working in healthcare. They publish a lot in healthcare sociology journals, and I don't think any doctor reads them. So our situation is probably similar. Then should we shout louder or shout differently? I think there are two aspects here. One of them is probably, is citation a good indicator of success in impacting healthcare delivery? And I'm not sure it is. But I mean, it's clearly not the unique indicator, and it's quite likely that we do affect healthcare delivery through other routes. Then on it again, I think there's probably a question here of what do we publish where and for whom. But the sample we had was a mixture of a few papers that were clearly aimed at designers because they were methodological in nature, or healthcare was just a sector of application, but the research question was really a design question. There were also quite a few papers that were, applications of straight classic design methods and classic design principles in healthcare. And because we're not using, the fancy keywords like design thinking or something like that, they were not picked up even by people who were looking specifically for design thinking papers in healthcare. So I think there are also simple things to do in terms of referencing our papers, of the use of the keywords we use, of the way we market them in a way, even though that's probably not the best expression towards healthcare researchers. And I've been talking a lot, so I don't want to keep the floor for myself.
Okay, there is also a question for Alex. I think you can comment a little bit on that. if possible.
Yes, thank you, Dorian. I think the first question came from Edward asking about how we define social well-being. And I think it is not the easiest to define. And the WHO model, that's the universal definition, I think would include everything that impacts on health. Even if your social situation is such that it has health implications, that will be included. So it's a very broad definition. But I think the reality is that I think as a society, we are at a place where the concept of health has become much broader. So in the literature, there are four models of the definition of health. The medical model, which is very traditional, the universal model from WHO. There are two others, the wellness model and the environmental model. The wellness model, I think, is much more ambitious, which is about a constant progress towards a state of better health, better energy, and a sound integration of body, soul, and spirit. So I think it's become much wider than even the universal model. So I think there's a lot of ambition around what we think health is. That would mean that designing health systems is not going to be the traditional care that we often think about, but I think there's a lot more to it. So I think the definition is not always very straightforward, but the reality is that we want much more than the absence of disease. There was a question from Mark as well in terms of public health and the personal health and systems and reductionism. And again, I think, at least from what I see, that we know that the reductionist approach is not sufficient, especially in places where we have complex health interventions, that we cannot reduce these things to things that can be controlled and trialed and tested. And so as an interest in systems approach is growing, and that's what we see. And so I think the reductionist model has a value, but it is not always the answer, especially when you have a complex intervention. So I think there's a growing need, and it will continue to grow. And I think, John, you might want to comment on this as well.
Any comments?
I think your comment is sufficient, Alex. I'm not sure I want to comment further. With an excellent response.
Okay. Let's go to Alex Feldman. Well, what I'm interested is because this research is quite, I would say, flavored by the case study, the nature of the case study, and also by the Danish healthcare system, which is one among the best I know. So how can we have a general lecture or how can we use this outside of these two, I would say, constraints? Because I would say the recommendation from this case study is very useful, but I would like to see it even more broader than from these cases. Do you plan, Alex, to go or to draw some recommendation for that are farther or broader than hearing loss and cognitive disabilities?
So I'm not sure. Alex might struggle with audio, and I'm actually not sure what Alex will say. I'm sure it's much better than what I will say. But perhaps I can help out a little bit.
Vanica, do we hear Alex or not?
No, unfortunately not. Alex, if you can hear us, maybe you can please try to refresh the page. Because we can see that you're trying to say something, but unfortunately it doesn't come to us.
Mhm. I think Alex will rejoin
Yes.
after a while. Okay, Anja, can you help with this, or we should wait?
Perhaps let's wait a little.
Okay.
Take one more question. If she doesn't appear, I'm happy to help out and give my best guess.
Okay. Let's go then to the third paper about atypical use scenarios as design integration in healthcare products design application. Kamya, what I'm wondering is how you differentiate a typical use from the use that could be expected because the design brief was not correct, or the designers have not thought carefully about what can happen with their designs in the regular everyday use. Since obviously with all medical devices, there is a problem that you have a trained personnel that can use devices or is using the devices regularly. And then you have also another group of users that is not trained and that is using these devices occasionally. Of course, there is a complete different approach to such devices. How you treat these cases?
Yeah, thanks, Prof, for this question. So, in terms of collecting the information for atypical scenarios, it was not that challenging when it came to this study that we did, because we collected information regarding atypical scenarios from clinicians for this particular study. However, for some of the products, the end users were patients themselves, which we did not approach them to collect insights for atypical scenarios. The clinicians represented for the patients themselves. So in this particular context of the study, it was not very challenging because the clinicians were able to define atypical scenarios, because initially we gave them an idea about what kind of atypical scenarios are we looking at. For example, an extreme condition that would happen, or the product that the students developed were the ones that was not existing currently, and the experiences were shared based on the current solution, the current device that the clinicians were using for the particular context that they were focusing on. So they were able to define the kind of atypical scenarios, such as the accidents that happened or the close calls, which could occur rarely, but if it occurs, they would want to avoid, which explicitly did not get mentioned to the teams during the initial discussions of user needs.
Thank you.
Okay, I'm happy to come in if it suits. I don't know whether Alex is back. Just about back. Alex,
I'm really going to
just
try.
about forming the answer. You go now.
Okay.
Yeah. All right. Yeah, I've been listening, but I haven't been able to contribute, which has been difficult. So yeah, just let me know if my audio cuts out or anything. But to start with the comment from Dorian, basically my intention was to be quite specific on not necessarily the Danish healthcare system as a sort of healthcare system concept, but more so about going into the actual regular daily practice of a clinic. So it wasn't necessarily to look into the Danish perspective of the attention towards hearing care in cognitive care, but it was more so to look at how sort of research and emerging research is actually implemented in practice. I think when it comes to the field of cognitive hearing science, there's no doubt that there is an association and a need to look at hearing loss in patients who do have cognitive impairment. And if you look at the Danish ministry's guidelines, they do say that it's recommended and that it's standard practice to look for sensory impairments when you're doing the sort of overall health diagnostic checkup on somebody who goes through the the healthcare system or the cognitive care system. But in practice, when you have a bunch of neuropsychologists and neurologists at the memory clinic, there wouldn't really be a chance to see whether somebody has mild to moderate hearing loss or even more severe hearing loss, unless that's something that's extremely evident in the sort of clinic checkup and the conversation with the doctor. So the way that I saw the project or the paper itself was a way to actually go into the day-to-day practices of the clinic and actually look at how we might be able to shed light and how we might be able to actually sort of create a new pathway where one didn't exist before. I'm hoping that you can still hear me.
Yes.
I think so.
Yes.
My internet's still being a bit shaky. Okay, perfect.
I can add
Yeah,
one
so
more
when it comes
thought.
to how to, of course.
No, I'll be out. Alex, is your stage. Sorry.
Yeah. Okay.
No, go ahead.
There is also another question for Alex from Mark in the chat window. Can you see it?
Sorry, I can.
Sorry?
Go on, Mark. You can rephrase your question, I
Sorry,
believe.
I pressed enter too early, and I thought it was too complicated to try and retype it and understand it. I do it in words, spoken words. But yeah, I suppose linked to the question I asked Alexander above, which is about how you sort of manage this tension of healthcare for an individual, which is incredibly complicated. And then you obviously have to manage a health system, you have to sort of reduce it down to make it more simple, such that you can manage such a large system like of, I don't know, population health or a nation's health. I suppose in your presentation, I guess you were talking about how you take a more holistic approach to managing people with neurological impairments, which is looking at sort of people with sort of hearing problems, but that is, you're proposing more interventions, more diagnosis. I suppose it's a more complicated diagnostic path, and whether you felt in implementing that there is much resistance from a healthcare system in doing that, because it's kind of, you're sort of asking more from it, even though in the longer term perhaps there are cost savings and there are beneficial health outcomes, but in the short term you have to do more, which makes it difficult. So I wonder what your thoughts on that might be.
Yeah, and I think a lot of that came from also just the resources or the agents that exist in the clinic. I think a big part of it isn't so much the lack of a desire to take a more holistic approach to geriatric care in general, but a lot of it is such that in healthcare systems and in Denmark, like in many others, each department sits in a very separate area. And in order to actually merge between these different departments, you would need a fundamental change in the system structure. So as it stands now, you would be unlikely to go into one department that deals with elderly care issues and be able to see a specialist who comes from another area, or even to see both specialists within one visit. They would probably happen individually in the separate areas. And I think what I'm sort of trying to approach with this project, or what we were exploring, is we brought tools and technologies from one care area into another area. And we did that because of the research project. But in doing so, we tried to take a closer look as to what it would mean to actually implement something like hearing screenings into a memory clinic context. And it's likely that that would require, in order to not overburden the specialists themselves who practice in another area, it would probably require the merging of two health departments into one, or a clear pathway to link between the two, even within the same building, so that they were able to bring and see patients between one and another more easily.
Thank you.
Yeah, so both from an interpersonal and sort of between people and specialists, but also with technology and tools. For example, to access a soundproof room to run hearing screenings would be difficult in the current clinic infrastructure. So it's those kind of aspects of the system that are quite practical that I think are helpful to do in the very sort of micro care system.
That's really interesting. Yeah, thank you.
Thank you both. I think there's discussion about holistic or reductionistic approaches to healthcare. I think this question be also addressed to the last presentation, because Edward has presented a really holistic approach to the problem. But what I'm thinking is, they have laid down quite specific recommendations how to design safe and clinically effective medical devices. Are there any further research on how these recommendations have been used and what is the outcome after the usage, if they have been used? Can you comment on that, Edward?
So you mean recommendations from the framework that was presented?
So you don't have any feedback after your recommendations have been used in practice?
Right. So what we've managed to do as yet is to sort of apply the framework as a case study. The case study that we've presented. As yet, the framework is still not validated, and I am stating this in my conclusion. So the next studies that we've planned for the coming weeks is to validate the framework with a set of designers working in medical device design.
Okay, thank you. Any other questions or comments from the audience?
Can I comment on that reductionist and systemic approach then, Dorian?
Yes, please.
Yeah, I think maybe I understood the question better when Mark actually spoke here, and I think if again I'm not mistaken, you asking about how do we actually appropriate the two approaches, so the reductionist approach and then the systems approach, given the complexity of medical care delivery. Is that what you mean, Mark?
I guess when I talk about a holistic approach, it's more about, I suppose, a holistic approach to health, which is obviously incredibly complicated, and you would need, a Western medical approach, you would need experts. You need all sorts of experts. Hematologists, and you need, loads of different sort of consultants to really get like a full picture of what your health looked like. And you need to sort of cover a lot of different bases, which is not feasible or possible within the resources of the system. And so you're kind of trying to manage what an individual's health looks like, but you can't manage everything to the nth degree as you would perhaps like to. So how you sort of work that trade-off, I guess.
Yeah, and I think a lot of what I do, it's not in a medical sense in terms of the clinical aspect of that and the complexity of managing the individual's medical health as such, but it's more about the system, the health delivery system. And my sense of that reductionist and the systems approach is that I think it's about what is appropriate for a particular situation, because I think there is value in the reductionist approach, but it comes to a point where the problem at hand does not justify the use of reductionist approaches. But are we just doing it because that's just the way we have done things? And I think it's about acknowledging the complexity of any particular situation and realizing that maybe for that situation, it requires a different approach. And what I find, especially doing stuff in mental health, is that the experience of patients at the end of the day is the result of so many different things interacting. You've got the clinician, information technology, medication, all of these things constantly interacting to deliver the outcome that we all desire. And that could be bad or good. And I think if we want that to be good, it cannot be left to chance. We have to think through how these things work together. And that's what I think we very much advocate a systems approach. So in situations like that, I think a systems approach is much more effective in actually trying to understand the context, the holistic picture on how these different elements interact. And I think, like you said, that when it comes to the medical or the medicine element, it's also complex. And maybe the systems approach applies there as well. But I think that hasn't been my main focus of work, but more the delivery system perspective, which I think requires very often a systems approach to making things better. I'm not sure if that answers your question, Mark.
Yeah, no, it does. No, it's very interesting. I suppose I've been, touch wood, very fortunate. I've not had to have much interactions with the healthcare system in my life so far. But I suppose recently I've been, my mum has been having cancer treatment. So she's been going in and out, having lots of contact with lots of different specialists and lots of different
Okay.
people in different areas, and you sort of start to see that how complicated a system it is and how joined up it isn't. And you realize how the kind of the lack of information flows between different people. You can really see the kind of the necessity for like a systems approach like you're discussing and presenting within the healthcare system, because it is all very complicated, and I suppose it's staffed and run by people who are incredibly talented and knowledgeable in their areas, but it isn't in systems thinking or systems design or the management of complex systems. So you kind of, it's difficult. It's really hard to get it all right. So yeah, thanks for your answer.
I guess this is a result from the subspecializations in medicine and health. As Mark said, yes, the things are extremely complex with diseases, and then the subspecializations leads to that attention of particular case is very narrow. And then the question is, what is a health system, and how is it just a collection of many different special cases, and or there is something that can be that is a general care for health? This is a question I'm not quite sure if you have the answer on that.
So, Dorian, that's something that we come across a lot in sort of healthcare systems research, and it's a real challenge. It's the difference between the pathway, which is what healthcare providers try to design as a pragmatic way of deciding what they deliver, and then there's the individual journey, which is what the patient or the patient's family experience. And I think it does come back to Mark's challenge that can we design a healthcare system which at least maximizes the possibility of taking a holistic approach to each individual patient? But they have a dilemma, because you've got the pragmatic fragmentation of the service so that each part can be delivered effectively by experts. The complexity comes from letting the patient loose to wander around the system, and those journeys do not always lie neatly on top of the pathways that have been defined. So I think we need to look at it at both levels. Holistically, how do we treat patients and members of the public? And holistically, how do we design the services and systems that have the best potential to match to the need of the individual? But it's a very interesting and difficult challenge.
Well, I agree with this. Yes, absolutely agree.
And I guess, John, it becomes a challenge of all sort of permutations and combinations, because you develop a pathway for one condition, but I suppose conditions rarely come one at a time. And so then somebody has sort of 4 conditions or multiple issues, and then there's no specific pathway, so people become unique in the system because of that.
There's a lot of unique folk who are ultimately on multiple pathways as part of a single journey, and that's where a lot of the complexity really does come into play. And it's often very difficult for particular specialists to come together. That is not part of their mindset, that they're part of these multiple pathways. I don't think there's an easy answer to this, Mark. I think for us as researchers, it's part of the challenge for us looking in from the outside, trying to understand this complexity and maybe analyze it in such a way we can suggest there are different ways of permutating the care that's provided. So as designers, engineers, we try and make things look too simple. That's not the reality. But maybe we have to do some of that at least to help people understand where that complexity lies and how it might be resolved. So I think we've got lots of work to do yet.
I agree with this, especially because the problem is, I would say, in healthcare system is the networking about all these special cases and merging them into the one net, where a specific case can be handled from all the viewpoints that are necessary. And from my experience, this is based mainly on individual basis of each specialist that is treating a patient. So there is a really individual pathways of for every patient. And this is quite opposite from the systemic view we are discussing today. So that means that we have quite a lot of things to do in front of us, and I hope we will have an opportunity. Also, there is another session on healthcare design on this conference, and I hope we will have opportunity to continue this discussion on the next conference in 2 years. Our session has come to the end. I would like to close it with a thank you for all the presenters. I know that presenting on pre-recorded presentation is not the most comfortable thing you have been doing in your life, but I hope you will join the next conference with the results of your PhD works in 2 years. Thank you very much, and see you later on. We have now a plenary session on the schedule, and also in the evening we have a gathering, I would say a social event in Gather Town, so please stay with us through the day. Thank you very much, and bye-bye. See you later.
Thank you.